the first step in everything. So all of the talk about AI, all of the talk about we'll build whatever the AI task force in the UK and all of that, and we'll create an NHS large language model. None of that can happen without the de-identification.
Yeah.
And this is also why we have done it. Like why we made this model, just because nothing before existed that was working good enough, basically. How many nodes did he anonymize?
Millions and millions.
See, like, I cannot even imagine that.
Yeah, he must have trained an army of people to anonymize these nodes. So, you know, I guess it brings us back. Maybe not everything needs AI.
No, this needs AI. This is not a question. Like, this makes no sense.
Welcome to Dev and Doc, a podcast where developers and doctors join forces to talk about AI in healthcare. My name's Josh. I'm a doctor and AI researcher in London, and with me today is
Zeljko, and I'm a developer at King's College.
That's right. And this week we're actually attending the American Medical Informatics Association Symposium in New Orleans. And we have seen a lot of interesting talk and posters about AI in healthcare. One that stood out to us today was actually de-identification, because we have a lot of big data in the electronic health records, but the question is, in order to put that to good use, we need to basically de-identify the nodes so we can essentially share the data and train large language models of it. Confidentiality is something that we care very strongly about, and privacy, and the question is, how do we traverse that in order to make it beneficial for patients and the wider community?
Okay, so I think what makes sense is maybe to say some things about personal health information or private health information. Mm-hmm. What is that, and why do we want to remove it? It's like, what does it all include? Everything that's included in PHI, so that's short for the personal health information.
So working as a doctor, one of my main concerns is privacy and confidentiality, because obviously we can't see a patient and then talk about it to other people who aren't directly looking after the patient or friends and family. This is one of the tenets of being a good physician, and is also part of the Hippocratic Oath to honor that. So that's one of the reasons why I really care about privacy, but it also extends further, right? So for example, in research, everything has to be blinded, and we can't be treating patients knowing who they are and what relation they may have with ourselves or other physicians, because that may actually alter the outcome. So it's very important to the scientific method as well.
For the scientific method, of course, just to prevent bias or prevent me searching for a specific patient and then treating that specific patient, not treating, but like researching that specific patient.
Exactly.
But also, of course, on the other side, just to protect the privacy of patients, because for sure many of them don't want the researchers to know what diseases they have.
Exactly.
Or they don't want to, they don't want anyone to access their private data, which is normal. I don't want that also. So that's why we need the identification part. That's why the first step, I think, in all of the first step you do, if you want to use the hospital data, is you de-identify it, and then you can do everything else. So I think that's also why we saw quite a few papers here. That's why we saw, I think, 5 or 6 posters.
Yeah, there were a lot.
Yesterday at AMIA, there was basically this poster presentation, a couple of hundred PhD researchers, postdocs, professors, everyone else comes together and presents posters about the work they do. And one topic that basically repeated like 5 or 6 times, which was the only topic, like everything else was almost unique, or there was no repetition, but the only one that was like 5, 6 papers was the identification. So obviously it's a big problem, and obviously it is a major topic that we need to solve. So what is like included in, what's everything that we want to remove?
So PHI stands for personal health information or private health information. And the way I think of it is anything that can be traced back to detect that patient or identify that patient. So whether that's someone with benevolence, intentions or malevolent intentions. So things like their full name, their date of birth, things like the hospital number, their private documents, so like passports, driving license, phone numbers, all of those things are very personal health information. Did you have anything else to add to that? Or?
I think what also a lot of people ignore, we also remove stuff from doctors in hospital.
Yes.
I think we also remove like phone numbers from doctors, phone numbers from even hospital names in the lot, which I was surprised.
Well, the reason is because there are some specialist units, right, or specialist doctors. So some doctors, for example, specialize in, I don't know, let's say neuroinflammatory disease, or like things like multiple sclerosis, or if you have a neuromuscular specialist, seeing that kind of doctor can give you a really good indication of what problems the patient is having.
Oh, yeah, that makes sense.
Or geneticists. So genetics are very, very tricky, right? Because even if you take away all the things I just said, the personal health information, the phone numbers, the name, if they have a super rare condition and they're seeing a physician who is looking after that super rare condition, like mitochondrial disease, or there are cases of syndromes that are only prevalent in like a few families in the entirety of the UK, you're going to be able to trace it back regardless. So this is very difficult.
Yeah, I was a bit confused, like, because you and I have basically been working on a paper and which was on the identification. So I was a bit confused when we were doing that like, oh, we are removing hospital names, which for me is like, okay, we removed the King's College Hospital, but that does not mean anything. But now I get it. Like, if you really have a very specific disease, then you go to a specific hospital for that, and then you can be traced back. Yeah, that makes perfect sense, I think.
Yeah, exactly. So should we talk about kind of different approaches that these posters and other people have tried in the past to tackle this problem of anonymizing or obscuring patient information? Yeah,
I think in the UK, the most prevalent, and even today, the approach that's most widely used is simply a vocabulary-based approach.
Yes.
Which simply means like, that can be used for like addresses, names, hospital names, and all of that, which just means like you create a vocabulary, a dictionary of every name ever. And if that name appears in a document, you remove it.
Yes.
But as you know, there are some problems with that.
Yeah. So, we covered this in the named entity recognition episode, and using a rules-based approach is basically sitting down and trying to write down all the different ways in which a phone number can appear or a name can appear. As you can imagine, it would take forever, and there's always, there's so many different ways you can write a phone number, so many different names.
Yeah.
It's very difficult, which is why we want to do something a bit more high-tech, right?
Yeah.
Using named entity recognition, or NER, and using different AI models. So I spoke to a lot of clinicians in AMIA, in the conference that we're in at the moment, and it's very surprising that some of them are still thinking about rules-based approaches.
Yeah.
I do think we need to shift away from that because just the way hospital records are written as well, it can be very variable.
Yeah.
And rules-based will never be 100% perfect.
And rules-based can also over-redact because, of course, like, imagine you are removing names and you collected every name ever.
Yeah.
And like, there is for sure a person called Parkinson.
Exactly.
Or with a surname Parkinson or something. Then you remove all Parkinson disease mentions from the document. So you basically overdo things a lot. And these, especially, the bigger your dictionary is, the more will these happen. So imagine you collected every address in the world.
Yes.
I'm sure there will be a lot of names, a lot of
staging
words.
systems.
Yes.
Yeah. And even scoring systems. So, like the King's College Hospital scoring systems for liver disease.
Yeah.
So if you obscure that, it may cause the model to not pick up on certain things. Or like you said, Parkinson's disease for Mr. Parkinson.
Yeah.
That would be, the fear is that you lose information, and then whatever model you train on a rules-based approach will have poorer performance because you've just over-redacted that text.
Yeah, exactly. So just to explain, like, why is it important not to over-redact? It simply means that if later we will be using that redacted text for something else, for another machine learning model or whatever, and we removed every mention of the Parkinson's disease, then it means like it will, our next model, everything down the road, will not really work. So that's why we don't want to over-redact, but there is a bit of a trade-off there always between like over-redacting and being precise enough. So under and over-redacting, so you want to be somewhere in the middle. I think in case of the identification, you probably want to over-redact a bit. I think you want to redact a bit more.
Be on the safe side.
Yeah, be on the safe side, exactly. So if you remove a couple of % of mentions of Parkinson's, I think it is okay, because for a Parkinson's patient, it will be mentioned 100 times. So if you remove 3 of them, no one really
And in the
cares.
name of protection, you'd rather be safe than sorry, right? You'd rather than expose personal information. But yeah, I mean, just giving some more examples, that's just popped into my head, you know, so the title, like Mrs. blah, blah. MRS is something that we commonly use to grade the functional status of patients. So that's an acronym.
And MS also.
MS, so multiple sclerosis. So there's so many ways that rules-based approach will fail. So should we talk a bit about how we can tackle this problem and how we move away from rules-based?
Yeah, no, of course. I mean, I do think people have started moving away from them. It is still like we said, even in UK is the most prevalent, and even here, you just mentioned, like, I was also surprised. I was thinking that it's a bit more advanced, that people have switched away from rule-based. It's not even rule-based. You don't even have rules, basically. You just have like a dictionary.
It's just a dictionary.
You straight like matching, which is one of the oldest. But the thing is also, it is the simplest approach ever. And it is the approach that in case of names guarantees 100% removal. Because the only thing that can happen is a spelling mistake, and then the matching doesn't work anymore. But otherwise, this will remove 100% everything. But it doesn't work for anything else. It works well for names, but like you go to initials, which is the worst case ever. So initials are very difficult.
J. Smith or whatever.
You want to collect every initial ever that exists. So that is like, that doesn't really work, and you'll remove a lot of other things and all of that. So that's why I think we need to move away and go to deep learning models, which was also a trend here. I think most of the posters we saw were really deep learning approaches.
And most of them use name identity recognition and linking as well. But so now the question is, but despite everyone using the same approach, there is such a wide variation in the results, right? Some people have great results, some don't have so great results. So the question is, why? And you know, the results for our model was very high. So the recall was what, 99%?
Yeah, we were above 99%. So 99 point, I think in the main hospital where we have done the test was like 99.8. Which basically means like the model makes a mistake 2 in 1,000. The question is that good enough? You know, that's the real question. How much would you say it's safe? Or how much is enough? Let's not use the word safe. I mean, 100% is impossible. No matter what you do, it's impossible. So what is safe? When I was building this, I was basically aiming for above 99. I was thinking like, if it's above 99, the occasional name or something will be left somewhere. And what can you do? There is no way to do that. And what is also good is that nearly never, not nearly, absolutely never, we will have a name and a surname together and that it's not removed. So this is impossible. Where names were left in our experiments were basically very weird cases. Like sometimes you'll have a doctor write a name at the end of a document without anything else. So it's just they make basically like come to the end of the document, blank space, write a name. And sometimes that name does not sound like a name. Like if you just write someone's first or last name, occasionally it can sound like very similar to whatever else.
Okay.
So occasionally the model will miss that. But if it's really like first, last name, full name of someone in text, there is no way that will be missed.
Okay. Okay.
So it is the weird cases that get missed.
But yeah, I've just remembered I spoke to one of the professors, Professor Boots, who essentially has anonymized all of his data in the University of California and the hospitals that are linked to it. And so he didn't use an AI approach.
Okay.
He used a manual approach. So he told me he hired big teams of people to anonymize these notes, and then they got it validated by an external company to say that they were like 99.99 or whatever percent HIPAA compliant, which I think is amazing, but also very manual.
Insane, to be honest. How many notes did he anonymize?
Millions and millions.
See, like, I cannot even imagine that.
Yeah, he must have trained an army of people to anonymize these notes. So, you know, I guess it brings us back. Maybe not everything needs AI.
No, this needs AI. This is not a question. Like, this makes no sense. He basically would have needed like hundreds of people over 5 or 10 years.
Yeah.
And
an army of people.
An army of people, exactly. And the model we have made does that in a couple of hours.
Yeah.
We anonymize like 10 million, no, more than 10 million. We now have around 20 million documents, and we anonymize that in a day.
Yeah, exactly.
So there is, I think, a big, and we are, I think, on a similar level. We are 99 point something.
Exactly.
And imagine if, like, the biggest reason or the biggest factor in why the models are good or bad are usually the quality of the training data. So if we or anyone else really wants to make this perfect, so what you want is a perfect training data set that is very diverse, that comes from like all different sources, and really make sure that it's exactly correct. That like you didn't miss a name, because the moment you miss a name, the model learns to miss that name, and they're like the model learns the wrong way, and then you have the
So you're talking about this manual annotation process now. So we get clinicians or humans or whoever to go through these notes and basically tell the machine what to anonymize and mark it, whether it's correct or incorrect on the ones that it has recognized. Yeah, so that part is actually essential, and that's probably the secret ingredient to how to build a really good anonymization model, right? Yeah. That's the difference between these posters, because I looked at one of the other posters. There's many ways to annotate, and some people maybe just do one cycle, some people have one annotator, some people have a team of annotators. The problem with bigger teams of annotators is that there's more variation, right?
Yeah.
So they need to be really aligned, and we talk about this concept of inter-annotator agreements. Yeah. So, you know, how much is person A versus person B annotating differently? If they're all very poor agreements, then the model will really struggle to learn, right?
Yeah, so this inter-annotator agreement, how you measure it, you basically give the same 10 documents to multiple people, and you check, are the annotations different? So how in the percentage of the annotations that are the same between all of these people and the percentage that's different. So that's how you get this inter-annotator agreement. Yeah. And yeah, so that's one of the main ways that people do it. You want to have that inter-annotator agreement close to 1. Yeah. Which means
one is a perfect overlap.
Yeah, exactly. Which means like everyone is doing exactly the same. Everyone understands the task in exactly the same way. And I was thinking it's simple. I mean, I completely agree that it is complicated for annotating diseases or symptoms or what, but I did not think it's hard for annotating. Like, you are annotating a name. It's just a name. Yeah. You cannot...
You think it's quite binary.
Yeah.
Like, that's a name, that's not a name.
Exactly. But the more you go into that, the more you see like different things. So sometimes someone like a person or a doctor or whatever will also have a middle name. So so we usually, when we are annotating, we have like first name, last name. We didn't have middle name. So occasionally someone will annotate the middle name as the last name, someone will annotate it as the first name.
Okay.
And sometimes you will also have the first portion as initial, so J.Smith, like for John Smith.
Or they flip it, Smith J.
Smith J or something. So someone would then be confused, okay, like, is this J now an initial? Or because it is now together with a name, is it also, is it a name? So like,
and Smith could be a first name theoretically.
Yeah.
Their name could be Smith Johnson or something, like Smith J.
Yes. So it gets so complicated that it is unbelievable. It is so hard to get the internotator agreement to be like really
perfect.
at one,
And even if the annotator agreement is good, it doesn't mean they're annotating correctly as well.
Yeah.
So that's the difficulty. And you really need to go deep into the health records to know whether whether Smith was the last name or the first name.
Yeah, I mean, that's true. Even though it is still one of the most important things is consistency, at least for training of the model. Even if, sure, okay, it can happen that the annotators are mistakenly annotating all together in the same way, first name as the last name, but you don't really care too much about that.
It doesn't matter, as long as they're all redacted, it doesn't matter, right?
Exactly, So you want to just be able to remove that, and the fact that you replaced a first name with a last name, who cares really?
Yeah.
The only thing you don't want consistent mistakes is missing stuff.
Yes.
So of course there you don't want to be consistent in missing a name constantly and then not redacting that once you train the model.
Yeah.
But so this part is in fact very difficult and very time consuming. So if you want to do these properly, what you basically need is multiple annotators doing the same thing.
Exactly.
So what you would have is you have so let's just mention this, like to train one of these deep learning models, it is usually recommended to go above 1000 mentions of something. So 1000 names, 1000 addresses, 1000 whatever. So imagine this, and then instead of having one person annotate these, now you need 3 people annotating the same thing. So annotating the exact same documents for the exact same entities. So you're basically tripling the amount of work you need to do because you now have 3 annotators, so that you can be sure that everything is removed. So you can be sure that they found everything.
But there's more than 1000 names, and way more.
No, of course, but this is, you hope that the model will generalize. You show it those 1000 documents with 1000 names, and then you hope that the model learn like, oh, this is a name, and then it will generalize to.
But would it be helpful to like pre-enrich it with a dictionary of, because obviously there are many dictionaries of names that exist online already. Can you like feed it that first? And
people do usually try that. It doesn't help at all.
Really? That's surprising.
It turns out most of these things we do manually don't help because it is extremely simple for the model to learn that. So it turns out like the model very easily understands what's a name. Where the model gets confused is when something can be a name and also something else. So that's where things maybe get problematic, and that the model has to learn, but it doesn't learn that from a dictionary. It learns that from seeing many examples of the one thing and many examples of the other thing. So this is like
understanding the context in which they're mentioned.
This is the Parkinson's example. The model sees 100 So if, for example, your model never saw a Parkinson's mention in a sense of a disease, then it would maybe have some trouble with that. But if it saw that 10 times, then...
And you've told it this is incorrect.
Yes.
This is not a name.
Exactly.
Then it will understand.
Exactly. So, but what we have done in the recent paper was basically invent a novel way to do that annotation so that we don't have to triple the amount of work, but we can still have just one annotator doing the annotations and have a bit of extra work after that, but maybe only like 50% more and not 300% more.
I mean, I've been using this approach for lots of the different projects as well. But do you want to run us through briefly the steps?
Yeah, I think it's extremely simple. Like, it is one of the simplest things ever, and I think that's also why it works so well.
In hindsight, you'd be like, oh, this is so obvious. There's nothing special about this. It's not really like groundbreaking AI. It's just a simple way to improve the annotation quality and thereby having a higher performing model.
Yeah, exactly that. So what you do is you do the first annotation round the same way. So you get your 1000 documents, you remove all PHI data from them, so you mark what is the PHI data, and then you train your deep learning model on that. But now comes the basically special part where you take these. So how you normally do this training is that you train the model on 80% of the documents and you test it on 20. So basically the model has never seen these 20, yes. And what you do in this second step is you train the model on 80%, you predict the PHI data, so you predict the PHI entities on the 20% of the documents that were in your test set. And wherever you have a difference between what the annotator said, so what the manual annotation said, and what the model said, you check that again. Because what this means is that if the annotator possibly missed something, maybe the model caught it. Or if the annotator wrongly marked something, maybe the model caught it. So if there is a difference, if you check now all the differences, and if all of those differences are really model mistakes, then that's it. Basically, that's because you reach the limit of the model. The model cannot learn more. You basically either need to increase your data set or get a better model. But if the differences are mistakes by the annotator, then you fix those and you train the model again. So you basically repeat this until all the mistakes are mistakes by the model. And if you in fact do this, you end up with only like very, very few. We would usually in the end up with like 3 to 5 mistakes on 1,000 that were by the model. And it would be like very strange cases. Like it would be things that even I'm looking at, I'm like, is this an entity? Is this a PHI information or not? Because sometimes it's very hard.
Exactly. So I guess phrased another way is you get the annotators to annotate the 100% of documents. You train the model on 80% and then run it on the 20%. And then you're just comparing in that 20%, what's the discrepancy between the model and the annotator? And we're basically trying to eliminate annotator mistakes. We want that to be 0. So if there's any discrepancies, we look at those. And if they're like false negatives or false positives that are created by the human, then we go back and change that annotation and then we retrain it until we get basically the most streamlined model.
So you might be thinking here like, okay, we are only testing the model on 20%, so we're only fixing the 20% and not the 80%. But here what you use is called folds. You basically do this exercise 5 times. So imagine the first time you take all documents from 0 to 800 and test on the 200. The second time you take all documents from 200 to 1000 and then test on the 0 to 200. So you are basically doing 5 folds, where in every fold 20% of the documents is a different set.
So in that way you validate all 100% essentially. But just quickly about folds, because I use 5-fold myself, but is there like an optimum fold?
No, not really. I mean, that depends on the size of your data set. Like you
5 is normally enough, right?
You can go with basically a fold just means how much are you leaving in the test set. So 5-fold means like 20% is in test set, 80% is in the training set. So but 10-fold is 10% is there, 90% is in the train. So and how much you take is really depends on the data set, depends on the model, depends on a million other things. But so there is no standard. But people usually take 5. Or 10 at most, but that's like that's it. And yeah, so this is, I think, what we have done differently from anyone else we saw here. And in this way also we get basically to that recall of 99.99%, which is, the rest of the approach is the same between us and everyone else here. Everyone else is basically just using a deep learning model, like this also goes into like large language models, so BERT or Roberta or any one of those. So which one you use is more a question of taste, not anything else. It's just like, pick this one, that's my, I like that one.
And the experiments show that they probably yield quite similar results, right?
Yeah, they are very similar. For whatever reason, in our case, the Roberta model was working the best, but the difference was like 0.1%.
But just playing the devil's advocate, using this kind of approach, you see great results. But how do you know, once you run that on millions and millions of models, how do you know it's not overfitting?
Yeah, I mean, that's always hard. Basically what you try to do here is try to do some confidence scores and some statistical analysis so that you are sure that the size of your sample is representative of the whole data set, and how much, basically the more the better. If you can annotate 100,000 documents, that is awesome. That is the best thing.
And then you run it on, let's say, millions of documents on the electronic health record. And then that's where the validation comes in, right? Then within that million, you want essentially someone, either a third-party company or the clinicians or whatever, to take a chunk of that data and basically read through and see if the model is actually performing at those metrics in the other documents.
Yeah, exactly. You are just doing, again, one more step of validation to make sure that we didn't miss anything.
And do you find that this model also works well in other hospitals, if you take this kind of approach?
Yeah, that's an awesome question. I mean, we have done this. So what we have done is basically you train it in one hospital, then you transfer it to another one, and you test the same thing. It doesn't work. It's not it doesn't work, but it doesn't work as well as in the first hospital. So, I mean, no hospital are the same.
No department is the same, and no hospital is the same. Just the way they write and the way that EHRs are structured causes you to type differently for whatever reason. But then that's where fine-tuning comes in and kind of transfer learning. So you take that model and then maybe you take a smaller amount of documents, you go through the same process again, but in like a shorter cycle, and then you can basically get really great performance to match.
No, exactly, So what you need in the second hospital is just a representative data set so that the model can learn the differences. The model already knows what are names and whatever, but does not maybe know the things that are special in that other hospital. So once you transfer it there, you maybe now sample 100 documents or whatever instead of that 1,000, and you fine tune a bit more, and you basically get to that 99% again.
So this approach presents a blueprint on how to basically do annotation the best way that we know how to, and to create a really good model with a high recall and high redaction rates. So once that's done, then the world is your oyster. So what does that enable us to do after? All kinds of things, right? If you have all of the electronic health record de-identified, we can build large language models, we could ease sharing of data, we can do more research. It's really one of the biggest barriers, right?
Yeah, exactly. It is the first step. I mean, if you even just sharing data between hospitals or creating like what in the UK is now happening, like trusted research environments, you want to still anonymize the data first and then put it in that silo where researchers can use it. So that's the first step in everything. So all of the talk about AI, all of the talk about we'll build whatever the AI task force in the UK and all of that, and we'll create an NHS large language model. None of that can happen without the de-identification. And this is also why we have done it. Like why we made this model, just because nothing before existed that was working good enough, basically.
Exactly. Yeah, I think this is one of the biggest steps. But I have seen people try and take a more convoluted kind of around the way approach to all of this. You know, you see startups talking about synthetic data, which is a big thing nowadays, right?
Yeah.
So instead of anonymizing and doing all this stuff, yeah, we have 99.999% recall, redaction, but there is still that tiny risk. So the question is, can you actually just train this data set and use an AI model to spit out a synthetic data set that then anyone can work with, and hypothetically it retains all of the data and the performance, and you don't have any of the downsides?
So you would still need the identification first. How these models work is that you first identify the data set, then you train, let's say, a large language model on that de-identified data, and then you use that large language model to generate clinical nodes.
Exactly.
So that model then generates clinical nodes, but those are now imaginary. They do not reflect any one of the existing patients, so they are a bit random, a bit all over the place. We hope, or those companies hope, that they contain still all the knowledge.
Yeah, this is tough.
But that's a big claim.
Yeah.
I do think like there is a lot of benefit in the synthetic data, and depending on the task you want to do, I think it can be a very good data set. But you have to be careful there. If you want to, after that, let's say, teach another language model on that synthetic data set to contain medical and clinical knowledge, I think that's a bit hard, because then you're also saying that the first language model, the one that generated the synthetic data, has all the knowledge. And that's a bit, those claims are a bit like,
claim. Yeah. I mean, so far studies show that any synthetic data set tends to be a bit lower in granularity and performance, and
diversity usually.
Yeah, that's the problem.
If something is rare, it is very likely that the language model will never generate it.
Yeah, but that's partly why it's also a useful tool, right? Because if you create synthetic models, then you can potentially increase the distribution of rare diseases if you wanted to.
True. Would have to be tested, I think, because the question is, would they all look the same? Like if you ask then that model to generate 10 clinical nodes for a patient that has, I don't know, give me a rare disease.
Yeah, I don't know, Church-Strauss or vasculitis.
Let's
say vasculitis.
No, but it's fine. Yeah. So yes, one of those ultra rare diseases. It is also a question: will all of those 10 clinical nodes look exactly the same? Because the model did not maybe learn enough diversity from the data, so it knows about that one type of person that gets that ultra rare disease. That would have to be tested. I don't know. Did anyone do some validation on?
I don't know. I see this. I only say it because I see the synthetic companies offer this kind of service that, increase the rare disease, or they have these proprietary equalizer approaches where they, I don't know, they balance something to do with race, to do with gender, but no one really knows exactly what they're doing under the hood and how that affects the final results. Very hard to say.
Okay, I think this is a good question. We could research that a bit in the future and just see, like, even just taking ChatGPT, generate 10 clinical nodes with a rare disease, and let's see, are they all following basically the same pattern? Which I somehow expect it will be very similar.
Yeah, I'd say so.
But let's see.
Yeah, I think either way, this is really the first step.
Yeah.
And there's so much work that we can build on it.
No, exactly, So I think, no matter what you do, you first identify, then do everything else. And in this way, you're helping patients, you're helping researchers, you're helping doctors, you're basically helping everyone. Okay, I think that would be everything for today. We covered basically a very, very important topic that quite a few people are still ignoring, so I think it will help. It should help some people to understand a bit more why is the identification so important, and why are we doing this.
Yeah, and feel free to read our paper, we'll add it to the link. And as always, feel free to like and subscribe, and also comment. We'd love to hear your thoughts. And that's a wrap.
Thank you very much for listening, and we'll see you next time.
Bye-bye. See you in the next one. Bye.